Thank you for joining our Debbie's Dream Foundation Curing Stomach Cancer webinar series. Today's webinar is titled Palliative Care, Support for Those with Serious, Life-Threatening Illnesses and Their Families, and this is the 12th in a series of 12 monthly webinars. I'm Mary Margaret Kilmeyer, and I'll be moderating today's webinar. I'm the Programs Director for Debbie's Dream Foundation Curing Stomach Cancer, and I'm a licensed marriage and family therapist. My clinical and research background is focused on working collaboratively with doctors, patients, their families, and the members of a healthcare team. We'd like to thank our title sponsors, Boston Biomedical and EMD Serono, as well as our platinum sponsor, Lilly Oncology, for providing the funding to make this webinar possible. You'll be able to ask questions during the presentation today. You can type your question into the white text box that appears on your screen. We'll address the questions at the conclusion of the presentation. In addition, the recording of this webinar will be accessible on our website in the lecture library. First, I will share information about stomach cancer, our founder, Debbie Zellman, and Debbie's Dream Foundation Curing Stomach Cancer. Then we will hear a presentation on palliative care by Dr. Betty Ferrell from City of Hope. The presentation will then be followed by a question and answer session. Many of you may be familiar with the facts and statistics about stomach cancer, and we are constantly working to be updated on them. In 2017, it was estimated that more than 28,000 Americans would be diagnosed with stomach cancer, and more than 11,000 would die from this disease. Most patients are diagnosed at stage 4, when the 5-year survival rate is only 5%, and the incidence rates in younger populations now is increasing. Yet, many know very little about this deadly disease. Pictured here is the the founder of Debbie's Dream Foundation Curing Stomach Cancer. Debbie was diagnosed with stage 4 stomach cancer in April of 2008. A practicing attorney and a mother of 3, she had no risk factors for stomach cancer, and her symptoms were very vague. At the time, she was told that her chance of being alive in 5 years was only 4%. She endured harsh chemo regimens and targeted treatments, as well as radiation treatments, and she experienced many recurrences over 9.5 years. Unfortunately, Debbie passed away on December 23rd of 2017 at the age of 50. She dedicated herself to helping others with stomach cancer by raising awareness and providing resources and education through this foundation. Debbie founded DDF in April of 2009, and as an organization, we're a member of several advocacy coalitions, including the Deadliest Cancer Coalition, the Patient Equal Access Coalition, the State Patient Equal Access Coalition, and One Voice Against Cancer. Debbie served as a patient advocate on numerous committees and task forces as well. And as an organization, DDF is working and will continue her important work and her legacy. DDF is dedicated to raising awareness about stomach cancer, advancing funding for research, and providing education and support internationally to patients, families, and caregivers. Our ultimate goal is to make the cure for stomach cancer a reality. You can learn more by visiting our website at www.debbiesdream.org. In a few short years, DDF has achieved many great milestones. We have 25 chapters across the United States, as well as chapters in Canada and Germany, and there are events ongoing around the country. Our patient resource education program helps patients and their families, as well as caregivers around the world by matching them with survivors and caregivers using disease-specific criteria, including their staging, biomarkers, and their location. We host educational webinars and symposia year-round, and our website contains in-depth information about stomach cancer that can be translated into more than 60 languages. We have also provided $650,000 in research grants and will award an additional $100,000 to researchers in 2018, bringing that total to $750,000. We advocated during our Stomach Cancer Capitol Hill Advocacy Day also to add stomach cancer to the Department of Defense's peer-reviewed cancer research program to increase federal funding for stomach cancer. And each year, we return to Washington, D.C. to maintain this funding that has become vital for researchers. These efforts have resulted in nearly $18 million being awarded to stomach cancer researchers over 3 fiscal years. And this is a current snapshot of our website's homepage, where you can find links to the numerous resources, including our stomach cancer support community, as well as our advocacy day and events that are coming up. And here is the listing of those events that we have on the horizon. The webinar that you're listening to today is going to be continued in a series in 2018 that will focus on advances in clinical advancement and research for stomach cancer patients and caregivers as the audience, and that will be a quarterly webinar. This Sunday is our 9th annual Night of Laughter in Fort Lauderdale, Florida, as well as our Capitol Hill Advocacy Day that I mentioned, taking place in Washington, D.C. on February 26th and 27th. Advocates from across the country fly in who are patients themselves, caregivers, or loved ones of a stomach cancer patient. And this is just an incredibly important event to attend and participate in to help change the landscape of research and funding at a federal level. So please consider joining us. Our 8th annual Stomach Cancer Symposium and webcast is also going to be taking place in Fort Lauderdale on April 21st, 2018, where we will host physicians who are experts in treatment of stomach cancer across the continuum of care. This symposium will be live webcast for participants who are not able to travel into Fort Lauderdale, and may also be accessible internationally. And then that evening, on April 21st, is our 9th annual Dreammakers Gala. This annual event celebrates the anniversary of the founding of Debbie's Dream Foundation, as well as our accomplishments throughout the year. For more information about any of those events, please visit our website and click on the Events tab. DDF is headquartered in Plantation, Florida, and our office hours are Monday through Friday from 8 a.m. to 5 p.m. Eastern Time. Also on this slide are the important phone numbers and email addresses that you can use to contact our staff. And so now we will begin the presentation, made possible in part by our title sponsors, Boston Biomedical and EMD Serono. The topic this month is palliative care, support for those with serious life-threatening illnesses and their families. Our speaker is Betty Ferrell from City of Hope. Dr. Ferrell is the Director of Nursing Research and Education and a professor at the City of Hope Medical Center in Duarte, California, and has been nursing for 40 years, focusing her clinical expertise and research in pain management, quality of life, and palliative care. And we thank you so much for joining us today, and I will now turn the webinar over to you.
Hello, thank you. I'm very glad to be a part of your webinar today and really honored to be a part of the important work of your foundation. As you mentioned, I've been in oncology my entire career, which is 41 years, and one of the things that I would say I strongly believe after 41 years is that the more information that people can have, the more involved they can be in their own care and advocating for their own care, or as family members advocating for patients, the better that it is. And so even though palliative care is a difficult topic, it's really challenging, I think, with any disease. As you've just heard, and you all know on this call, that stomach cancer is often diagnosed very late in the course of disease, that these are topics we wish weren't true and we would like to avoid, and yet talking about palliative care is one of the most important things that we can do in order to remain focused on quality of life. So what I'm going to be doing in this presentation is to share with you some thoughts about the field of palliative care, which has grown significantly over recent years, and I think has particular application to caring for people with stomach cancer. And then I'll share some examples with you and try to give you as much information as possible, and then we'll pause, and I'm glad to answer any questions that you have. So we'll begin with the first slide that you see. You'll see that the first thing is palliative care can provide many options to improve quality of life. And so often the moment someone hears the words palliative care, they immediately think, isn't that hospice? Isn't that just focusing on patients who won't survive, or patients who are at the very end of life. And yet a very important issue is that palliative care applies from the time of diagnosis, that as early in the course of your care that you can be connected with palliative care, the better things will be. And the intent of palliative care is quality of life. What can we do to improve each dimension of your life? At the City of Hope, over the last 28 years that I've been here, we have developed and used a model of quality of life across many, many populations and many studies. And so the dimensions of quality of life that we always refer to are physical, psychological, social, and spiritual. So physical, meaning your symptoms and your function. Psychological, things that are, of course, a normal part of living with a serious illness, such as anxiety and depression, fear of recurrence, living with uncertainty. Social, meaning interactions with your family, and also spiritual, because living with a life-threatening illness, of course, carries with it many existential or spiritual concerns. So, as listed on the slide, we want good palliative care as a part of good cancer care so that we can address physical and psychological symptoms, so that we can explore spiritual or existential angst, so we can provide grief and bereavement services for families, and so we can support family caregivers as they care for patients facing stomach cancer throughout the course of illness, however long that may be, and for survivors as well. So moving on to the next slide. So the next slide is a definition of what is palliative care, and this particular definition comes from the World Health Organization. So it's also really important to know that palliative care is not just something that exists in one hospital system or one part of the country. Palliative care is a very important concept and system of care around the world. So the World Health Organization, the same group that addresses other major public health concerns or health system issues, has been a very strong advocate for palliative care. And their definition says palliative care is an approach that improves the quality of life of patients and families facing the problem associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So again, you see those same domains coming up again and again. So just looking again at this definition, it's so important to emphasize right there in the second line, quality of life. And then a couple of lines later, focus on those words, prevention and relief of suffering. You know, so often in healthcare, we wait till there's a problem. We wait till someone's severely nauseous, and then we think about what we could do about the nausea. We wait till someone is already so severely cachectic, they've lost weight, they're having such problems with nutrition, and then how can we address that problem? But as I'm sure everyone realizes, the earlier that we can address problems and prevent problems, the more that we can reduce suffering. And so palliative care, when palliative care providers are assessing patients, they're not just concerned with what symptoms that you have today, they're concerned with what symptoms may lie ahead. Or for example, if you're starting a new treatment, a new chemotherapy or new treatment, it's so important to ask, what new symptoms might I experience because of this new treatment, so that you can be prepared for that symptom. And then once again, you'll see this definition ends with palliative care isn't just about physical problems such as pain, it's about psychosocial and spiritual issues as well. Let's go to the next slide. This is another definition of palliative care. The Center to Advance Palliative Care is an organization in New York. It's a part of the Mount Sinai Health System, and CAPC has been a leader in promoting the growth of palliative care across the country. And their definition says palliative care is specialized medical care for people with serious illnesses. It is focused on providing patients with relief from the symptoms, pain, and stress of a serious illness, whatever the diagnosis. The goal is to improve quality of life for both the patient and the family. So this definition from CAPC helps us to think even a step further. So, for example, of course, we want all medical oncologists, all gastroenterologists, all pulmonary doctors. We want everyone who's caring for people who are seriously ill to have an understanding of palliative care. But as you all know, medical care has become very, very complicated. There's so many medications and treatments available, so many diagnostic tests, that it's really hard for any one discipline to take care of everything. And so the field of palliative care is specialized medical care. Palliative care focuses just on these issues of serious illness and quality of life. And, sometimes patients are reluctant to see palliative care. So maybe their primary doctor or their oncologist might suggest, maybe we should call palliative care. And patients and families may say, oh, no, not yet, or, not another doctor, because they're just hesitant to add someone else into their care, or maybe they're hesitant because they think palliative care is only for people at the end of life. But the way that you should think about palliative care is that it really is just another medical specialty. If you were having a complex infection and your oncologist was really struggling with how to get on top of this infection, you wouldn't say, oh no, let's don't call the infectious disease doctors, right? You would say, yes, bring them in. If someone has greater expertise, bring them onto my team. And the same thing is true. We should be eager to embrace palliative care as another specialty that has special knowledge and experience in helping with quality of life concerns and serious illness. Palliative care specialists are particularly good at complicated symptoms, managing pain, dosing medications. As I'm sure everyone on this call knows, sometimes you're having a symptom such as pain. You take medication to help the pain, but in the process it makes you constipated or it makes you very sedated. And so, you solve one problem and you get two new ones. And so palliative care is just really good at managing multiple medications and titrating medications. And palliative care is accomplished through an interdisciplinary team. Palliative care works not only with specialized physicians and nurses, but chaplains and social workers and psychologists and others that can offer the psychosocial and spiritual support. So palliative care is something that should not be delayed. It's something that should be really embraced as a new component of our healthcare system, but it's vital for quality of life. Going on to the next slide. So just to summarize, what does palliative care do? Palliative care addresses the suffering. It addresses the physical, the psychological, the spiritual, the existential. One of the ways that we often think about this is probably a lot of people are very focused on your stomach, right? Where is the tumor? What's happening? Palliative care's job is to focus on the human being around the tumor, that the whole person, not just your stomach. And while stomach cancer may be the diagnosis, you are a whole human being who, because of your stomach cancer, you're having other physical and psychological and social and spiritual aspects of your illness. The focus is improving quality of life. It is a team approach to care, and patients and families decide what their goals of care are, not the healthcare team. we realize that it's so easy in the healthcare system that you give up being a mom, a sister, a spouse, a person, and you become a patient, another medical record. But one of the important focuses of palliative care is to also remember that you are a human being and that your life is very different. There may be 50 people with stomach cancer being treated in this clinic, but every single one of those people is a different person, a different story. You are a person with stomach cancer, but you're caring for young children. Maybe your spouse has a chronic illness. Maybe you're caring for elderly parents. So we have to know who you are as a person, who is your family, who's caring for you, and who do you care for in order to provide the best goals of care. The last bullet here emphasizes that one of the benefits of palliative care is to promote excellent communication, helping you, what do you need to convey to your providers, and what questions do you have for them, allowing you to make good decisions about your care. And again, as I've said, you can imagine I started my work in oncology in 1977. It was a very different time. Things have changed a lot. And yet what I have seen from my first day in oncology 41 years ago is that patients and families who are well informed, who are able to express their needs, ask questions, be really clear about who they are as a unique person, these are the people who can really do the best possible in facing their illness. Let's go to the next slide. This is from a public opinion poll. When palliative care is introduced appropriately, 90% of Americans say they're very or somewhat likely to consider palliative care for a loved one if they had a serious illness. So, of course, who would not want care that is going to see you as a whole person, help you across each of these dimensions, and have a focus on quality of life? But in reality, we know that palliative care can also be a scary word because we often want to focus just on the cure of disease. Here in my work at City of Hope, one of the major areas of my current focus is I'm doing a large NCI-supported study on integrating palliative care for our patients who are on phase 1 clinical trials. So patients who are coming to City of Hope as a comprehensive cancer center in order to participate in clinical trials and try to get, the latest, the best treatment. And so people come to us, saying, I'm here because I want to participate in a clinical trial. I want, even though other treatments haven't worked, I want to try everything. And so I often hear patients say, well, if I ask my doctor for a palliative care consult, he or she may think that I'm giving up, or I don't want to distract my oncologist, from focusing on my stomach cancer, so I'm not going to ask about palliative care. I even hear patients say, I'm not going to tell my doctor that I've lost more weight, or I'm not going to tell my doctor that my pain is worse because I don't want the doctor to think that I'm too sick to get more treatment. So in fact, while we all, think palliative care is a great idea, we have to be honest in saying that there still are barriers that interfere with patients accessing palliative care, even when it could really help them with their illness. Next slide. So as I've mentioned, people often confuse hospice from palliative care, and so I thought it would be good to really distinguish these two things. The left side of this slide summarizes what are some of the key elements of hospice care. Hospice is care that is provided when patients are considered, quote, terminal or having less than 6 months to live. It's provided when the patient and family have chosen not to receive more aggressive, curative, or chemotherapy kinds of care. It focuses on care versus cure, and expenses for hospice are usually covered by Medicare, Medicaid, or private insurance. In terms of palliative care, ideally begins at the time of diagnosis of a serious illness. And I can tell you we're not quite there yet, but across the country there are many institutions that are beginning to say, when we have diseases such as stomach cancer, pancreatic cancer, often lung cancer, diseases that are often diagnosed at late stage disease, or even if diagnosed earlier, these are diseases that we know bring with them a lot of symptoms and quality of life concerns. It should be routine practice that at the time someone is diagnosed with stomach cancer or other cancers, that we should begin palliative care immediately. As you can see with palliative care, there is no life expectancy requirement. Palliative care is beneficial for people who have a short time to live or people who may have many years to live. It can be used to complement curative care, that if we're treating your pain and symptoms and supporting you and your family, then that will benefit you so that you can stay on treatment longer, that you can live longer. Expenses for palliative care programs are often covered by philanthropy or fee-for-service or direct hospital support, but most health insurers do cover palliative care as they would other consults or other aspects. And for pediatric patients, care is also provided. And so, again, palliative care applies from children all the way through older adults. Let's go to the next slide. Palliative care is committed to providing interdisciplinary care so that we can provide attention from a variety of professionals. The key elements of palliative care are the 4 key disciplines: medicine, nursing, social work, and emergency. But palliative care teams are frequently reaching out to other people. For example, at my own hospital, City of Hope, and many other settings, we have child life specialists. And child life specialists are really important so that when we have adult patients who have young children, it's so important to pull in our child life specialists so they can help explain to children what their parents are going through or help address their coping, their suffering. And so the palliative care team is always thinking about what other professions within the institution could be a part of the care. Another really important principle of palliative care is that the family is the unit of care. We never think about one person. It's never just Susan is our patient. It's always Susan and her family are really our patient, the whole unit of care, because we need to constantly be asking, well, what does this mean for your family? And we define family very broadly. The family is whoever is family to you, whether that be friends, extended members of your community, that we need to know who is important to you and how we can support the family. On to the next slide. Palliative care is also very committed to respecting and honoring the patient's culture. We are, and it's a very good thing, that we are a very diverse society. And so part of palliative care's commitment is to pause and to really ask, who are you, as a person? Tell me about your culture, and whether that be factors related to your ethnicity or your race, your gender, your sexual orientation, beliefs and values, communities that you are a part of. We need to know who you are as a person in order to plan the best care for you. Palliative care provides care wherever patients are, and so in outpatient clinics, in inpatient hospital settings, in home care, in nursing homes, across settings of care, palliative care is becoming more and more a part of the way that healthcare is delivered. Next slide. Palliative care also exists to promote excellent communication, allowing patients and families to make good decisions. We could talk for hours just about this topic of communication. But what we know very well is that there's kind of something that's really a challenge. the sicker that you may be or the more serious an illness you have, the more important it is that you have good communication with your providers. And yet, what we also know is that when you're diagnosed with a disease such as stomach cancer, sometimes you're so overwhelmed, you're so frightened that when you are in the clinic, when you're in the hospital, you tend to, you may tend to be very quiet. You may tend to not ask many questions because you just feel so overwhelmed by the serious illness. And yet, as you can see, the more serious your illness, the more that it has an impact on your quality of life, the more important it is that you have good communication that goes both ways. Communication that both allows you to ask questions and express your needs, and communication that really requires your providers to be good communicators, to give you good information, to listen to you. And communication is very linked to caring for the whole person. For example, one of our colleagues is Harvey Chachinoff, is a psychiatrist who's very well known in this field. And he recently did a study where he compared the difference between patients who went through just the usual history and physical exam, and then in a second group, they went through the usual history and physical exam by their clinician. But at the end of that, the clinician paused and asked the patient one question. And the one question was, what should I know about you to provide the best care for you? What should I know about you to provide the best care for you? And, in asking that one open, inviting question, patients were able to say, well, what you should know about me is, I'm a 40-year-old woman with stomach cancer, but I'm the primary caregiver for my mother who has Alzheimer's. And so when you talk about what treatments I'm going to go through, I need you to know I still have to take care of my mother. That's really important information for us to know, right? So caring for the whole person, communication, these are really important. The last bullet on this slide also says palliative care, one of the hallmarks of palliative care is also very committed to bereavement services, grief support. So whether that is providing grief support for patients and families in the last stages of illness, or providing support to families after the death of a patient. This is really important. So palliative care is really built on the field of hospice care in saying care doesn't end at the time of death. Our care should extend so that we continue to support families even after the death of the patient. Next slide. So this is a case example. Monica is a young mother with stomach cancer. She's 36 years old. She's the mother of 4 young children. She was diagnosed at an advanced stage. At the time of her diagnosis, she was already experiencing nausea and vomiting, fatigue, weight loss, and anxiety, all that probably became a little worse with the start of her chemotherapy. Her husband, Mark, has his own business, so if he misses work, he doesn't get paid. There's no family in the area, like many families, particularly young families now. We're very scattered around the country. There's no family in the area to assist with child care or her visits to the cancer center. She thinks constantly about what would happen to her if she dies. And spiritually, although she's always considered herself a religious and spiritual person, she has to wonder if God is punishing her. After all, how could she, as a 36-year-old mother of 4, good wife, good person, be diagnosed with such a serious illness? Next slide. So what could palliative care provide for Monica and her family? Well, it could provide good interdisciplinary care in order to address and manage her symptoms. Try to do as best we can about getting control of nausea and vomiting and fatigue and weight loss and anxiety, because you know that every one of those symptoms is taking a big toll on her everyday life. Address goals of care. What does that mean? Healthcare providers more and more are using this term, goals of care. Goals of care means What is important to you? What is your goal in seeking care for your illness? If your goal of care is, I want to be aggressive as possible because I need as much time as possible. So in Monica's case, she might tell us, I realize my options are limited, that I have very late stage disease, but I'm young and otherwise healthy, and I really want the most aggressive care because my goal of care at this point in time is to live as long as possible because I've got to get things in place. I have these young children. My husband is, just left his job and went out on his own last year. We are in a really difficult place. Those may be very different goals of care than someone who is later in life and who says, my children are raised, my grandchildren are all well cared for. I have other chronic illnesses, and I really, there are limits as to how aggressive I want to be in treating my stomach cancer because my comfort, my quality of life is really important, more important to me than living longer. Other things that might be provided are providing attention to the children. So we need immediately to be aware of Monica's children. What are their ages? Developmentally, what do they understand about what's happening with their mother? Having a social worker address the financial and child care concerns. Having a chaplain visit to discuss her concerns that God may be punishing her. And all members of the team would meet frequently to discuss her ongoing care. Because as care proceeds, we need to all be connected about what will be the best support. Next slide. So how do I know if I need palliative care? So these are some of the things that might tell you could really benefit from palliative care. A need for symptom management. If you have any symptoms that are troublesome or out of control. You need assistance in making difficult medical decisions. Perhaps completing an events directive and knowing what your decision would be about prolonged life support. Addressing spiritual issues. Assistance in addressing practical needs for patients and families. If death is imminent, obtaining information on how to really use this time as best as possible. How do I reach out and say to people that I love you or I forgive you, I will miss you. So really having people who are not a part of your immediate family that you can really sort through some of your relationships or your communication with others. And desiring bereavement care for family members could be a reason why palliative care could be involved. Next slide. So how do I talk to my healthcare provider about palliative care? Sometimes your healthcare providers are reluctant to offer palliative care because they too may think, I don't want my patient to think I'm giving up on them. So if you have an oncologist that's cared for you from the time you were diagnosed with stomach cancer, they very much have been trying to provide the very best care possible. They may be reluctant because they don't want you to think they're giving up on you. But you need to let your healthcare providers know that you want a palliative care consult because you need extra help with symptoms or spiritual needs or emotional needs. Refer to your plan of care and remind your healthcare provider your goals. As you know, my goal is to be able to live as long as I can, but care for my children, concern for my family has always been the highest concern for me. And as always, if you need a second opinion, to have someone evaluate and support you in getting a second opinion about your care or about palliative care, you should do that. You should never hesitate to be your own advocate. Next slide. Can you keep your primary care provider if you choose to have palliative care? Absolutely. The way to think of it is palliative care is not an add-on to your care when everything else fails, but it complements the care that you're already receiving from whoever the primary care provider may be. And just like your palliative care provider, your primary provider, which in your case is likely an oncologist, would contact a cardiologist if you had a heart problem, your provider would contact a palliative care professional to assist in your care. So your palliative care is just an extra set of hands, an extra layer of support for you and your family. Next slide. So is there research that supports palliative care? Yes. When compared to standard non-palliative care, patients diagnosed with, this is one of the major studies that really started this whole field of integrating palliative care in good cancer care. This is a study at Massachusetts General Hospital, published in the New England Journal of Medicine, that patients who got palliative care as a part of their cancer care had better quality of life, less depression, and in fact lived longer. And they're now, we've done a study at City of Hope that documented patients living longer because of palliative care, and other studies have followed. Because it makes sense. If you get your symptoms under control, if you're getting psychological and social support, then it probably means you're able to tolerate treatments better. It means more support for you. And so it's been kind of an interesting thing that while palliative care is not focused, that's not the primary goal, longer life, what we're seeing increasingly is people live longer who are also receiving palliative care. Next slide. So I wanted to just share with you the information that I've provided is a part of one of my major projects, the End of Life Nursing Education Consortium, the LNEC project, which is a national and international training program in this field of palliative care, which is a partnership between my organization, the City of Hope, and the American Association of Colleges of Nursing. So we've been training nurses, physicians, and other providers around the country and around the world in this field of palliative care. Next. And there's some references added on of some of the things that are mentioned in these slides that you can look at later. And next. So I think we're at the point now for questions and answers. And so you'll be entering any questions, and then the staff will be fielding those questions. And I'm glad to address any questions that you might have.
Yes, thank you so much, Dr. Ferrell, for your presentation. It was both comprehensive and so informative, and we're really grateful for your time today. So we do have a few questions that came in while you were speaking, and for those who are listening, please feel free to continue to submit questions as we read through. So some you actually responded to in your last slides about what a patient should do to ask for palliative care. So we appreciate that. But a more specific question is that what should a patient be asking for? Should they ask for a specific referral for palliative care, or if they identify a specific need like psychosocial, spiritual, or nutrition support, should they say, can I speak with someone from that arena?
Yes, thank you. That's a great question. And I think what I would encourage anyone to do is, so it's your next clinic visit, or maybe you're calling in to check into the clinic, is to really ask just the broad question, to say, I really appreciate you all are taking such good care of me, and I just so appreciate being able to stay connected, and I know you're all working so hard to help me with my stomach cancer. I wanted to ask, I've heard a lot about palliative care. I've talked to other patients who've been seen by palliative care, and I think that would really help me. I'd really like to have a palliative care consult. And don't be surprised if your providers may say, is something wrong? And so, you just have to coach them. You have to say, no, I'm so grateful for your care, but, there's so much going on for me and my family because of this illness. As I am still having a lot of symptoms. I'm just, really struggling because this is just such a tough disease and tough treatment. And so I just think having an extra layer of support, having a team to just focus on like quality of life issues, would be really helpful. Anytime someone is seen by palliative care, it's I mean, the way to think about it is, if you went to see an infectious disease doctor, you can bet they're going to draw some blood, right? That's the way infectious disease works. They're going to have to know what's going on inside you. They're going to check your fever. They're going to order some tests. They're going to look at your blood. Well, the way palliative care does their work is that for whatever reason you go to palliative care, they're going to start by doing a whole person assessment. They're going to ask you about your symptoms psychologically, socially, spiritually, how you're doing. And so then they're going to sort out, who might help you. So I think I would just encourage you to, kind of ask the global question. I would like to be seen by palliative care. And then kind of let palliative care, sort out. The other thing I'll tell you is, palliative care, they're very good at, they know these dynamics of coordinating care with other disciplines. And so once a patient is seen by palliative care, there's sort of an etiquette, as you probably may have witnessed with, between other professionals already in your care. And so the palliative care team is going to then get back with your oncologist and say, thank you for referring Susan to us, and we really appreciate the opportunity to help you with her care, and here's our recommendations. Now, what happens quite often is then it really varies by provider. Sometimes the medical oncologist will say, she really does have a lot of symptoms and challenges, so I'm so, great, glad to have you on board, and I think it'll be good if you can really sort of take over helping her with some of these symptoms, because you all are, really good at these tough symptoms. So in that way, it would be what we would sort of call a shared care model, that your oncologist will just stay more focused on your stomach cancer, and the palliative care team will kind of take over symptom management. But in other instances, the oncologist may want to still sort of stay in charge of everything. And so in that case, the palliative care team would be making recommendations. Here's what we recommend for the nausea that's not responding so well to other drugs. Here's what we recommend for the pain. Here's what we would suggest for the depression. And so the medical oncologist still really remains the primary provider, but then, maybe you would follow up, in another month with a palliative care team, or your oncologist would call on the palliative care team. So every situation will be a little bit different, and each hospital does things a little bit differently, or each cancer group does things a little bit differently. But I think the key thing is that, you're asking for something that will benefit you and your family. And so you just, should be, very bold and confident in saying, I'd really like a palliative care consult. I think it could really help me and my family.
Great. Thank you so much. And again, I think you started to broach the subject of this next question, but just to make sure that the person asking got the clarity is, who coordinates the interdisciplinary team when those referrals are made? Who becomes responsible for that the actions are taking place, I guess?
Mm-hmm. Again, there is some variation from patient to patient. So let me give you an example. So let's say, and this is just, I'm just sort of making this up, but maybe it will kind of help. Let's say that we have an oncologist treating stomach cancer, and he has, a patient who has, things are pretty well under control, pretty good family support, but this, they've sort of tried everything, and the patient, they just can't get the nausea under control, or the patient is having some real depression that they've kind of tried everything, and it's just still, the patient's had some adverse effects from the medications they've tried. Things aren't going so well. So that may be a case where the oncologist, asks palliative care to see this patient, but then palliative care is able to the palliative care sees the patient and says, we actually do have some recommendations. There's some newer medications that maybe your oncologist doesn't even know about in these symptom management areas, or we have a few ideas, but they're pretty simple fixes. And so the palliative care team may be the first to say, what, we're going to reconnect with your oncologist. We're going to share our recommendations, with him. We think this is probably going to really make things better for you, and you probably don't need to come back to us, but we're certainly here if you need us again, and we'll certainly convey that to the oncologist. So that might be an instance where we all know patients are busy and overwhelmed, and one more trip to the hospital, one more clinic visit, if that can be avoided, we don't want that. That may be an example where a one-time consult is what you need, and your primary oncology team still needs to be, the key team taking care of you. And then that same doctor may have another patient that the patient's having multiple symptoms. The patient who just seems to have really strong, drug reactions. Maybe it's a patient who also has other illnesses, lupus, arthritis, other illnesses, diabetes, that are really making the stomach cancer more challenging. Or, maybe this is a situation where there's a lot of family issues, that there's, some real challenges some strain within the family, a recent divorce, a estranged child, lots of other, financial or social burdens. And that may be an instance where the palliative care, it's just, you have so many needs that are complex that the decision is going to be made that you're really going to need palliative care to follow alongside and to continue to see you throughout the course of your illness. And in that case, the palliative care team, they're usually the palliative care teams, meet weekly as a team. They sit down, they review the patients, and there is kind of a system in place from palliative care in terms of who's going to coordinate. So, for example, the palliative care nurse or nurse practitioner on the palliative care team may be seeing you, but she may decide, wow, you've got 3 young kids, we really should get child development involved, or child life involved. And so that nurse is going to reach out to child life, but still that nurse and the team are going to keep track of the big picture. So it's I think it probably makes this a little bit harder to understand, but in the big scheme of things, this is the beauty of palliative care, is that it's not one size fits all, and that the care, what makes palliative care what it is this attention to you as a unique person and what kind of care you need and how it needs to be coordinated.
It certainly does sound like a very patient-centric approach that offers a lot of flexibility.
Yeah.
Okay, thank you. And I think we have time for just one more question. And the one that came in, I think would be helpful is, what is the difference between integrative medicine and palliative care?
There are a lot of confusing terms: integrative medicine, complementary, care, complementary and alternative medicine, palliative care, etc. And integrative medicine can be defined in many ways. When I hear the word integrative medicine, what I generally think of is treatments that are outside of the sort of biomedical approach, so beyond chemotherapy, radiation therapy, surgery. Integrative medicine brings in all of the many, many other valuable things that can help you, from acupressure, acupuncture, hypnosis, music therapy, other alternative and complementary treatments, faith-based therapies, traditional healers, that, again, the richness of care that really honors your culture and respects you as a person. of course, needs to include everything, anything that could benefit you. So when I think of integrative medicine, I think of, integrative medicine is the broadening of the scope of care beyond what is often very medical, very pharmacologic focused. Palliative care is a medical specialty, and so people who go into palliative medicine go through, fellowship programs and specialty training so that they learn about palliative medicine in the same way your oncologist learned about oncology. Palliative medicine frequently calls on many other disciplines. So when you're being seen by palliative medicine and they're evaluating your psychological, social needs, then it's very common for palliative medicine to suggest or, bring in complementary, integrative kinds of therapies such as relaxation, imagery, hypnosis, yoga, the many, many other therapies as a way to help those, psychological needs. So I think, and again, I know that people define these terms in really different ways, but what I would say is that, palliative medicine is a field dedicated to symptom concerns and quality of life frequently relies on a broad range of other therapies to become a part of your treatment plan.
Thank you so much for that clarification. And unfortunately, we are out of time for questions today, but I'd like to thank you, Dr. Ferrell, for joining us and sharing your expertise with our population and our attendees today.
I'm very glad to be a part of your foundation, and I'm just really so impressed by all the great service that you offer and resources, and it's of great benefit to our patients at City of Hope as well. So thank you for all that you're doing, and appreciate the opportunity.
Absolutely, thank you. And for everyone listening, as you know, this webinar was brought to you today by Debbie's Dream Foundation, Curing Stomach Cancer. The recorded version of this webinar and all of our past webinars can be found in our lecture library on our website. Just as a reminder for you to check the website also for any of the upcoming events that are in your area. There are many more than are just listed here, so please be sure to look at the events page. We would like to thank our sponsors who helped make this webinar possible, our title sponsors, Boston Biomedical and EMD Serono, as well as our platinum sponsor, Lilly Oncology. I'd like to thank all of our listeners today, and as well as our speaker. This concludes our 12th in a series of 12 webinars. Please be on the lookout for information about our new webinar series that will be starting this year. To view any of our recorded webinars, again, please visit the lecture library and search by the topic that you might be interested in. We would love to hear your feedback, questions, and thoughts about any of our educational programming and services offered. Please send your comments and or your questions to patient.resource@debbiesdream.org. Thank you so much for joining.